plantar to the MTP joint, with most pathology occurring at its attachment onto the base of the proximal phalanx. Plantar plate abnormalities are common in runners and become more prevalent with age. However, they are often asymptomatic, making it important to correlate sonographic findings with sonopalpatory pain. When assessing the plantar plate with ultrasound, it should be evaluated in both long and short axis views. In the long axis view, I gently flex and extend the toe to place tension on the plantar plate, which often reveals the full extent of a tear. In the short axis plane, I carefully image the plantar plate to its insertion onto the proximal phalanx to assess for any associated bone abnormalities at its enthesis. The short axis cineclip on the right demonstrates a dynamic scan of the plantar plate from the MTP joint to its attachment onto the condyles of the proximal phalanx, as labeled. In the case of this triathlete, the long axis cineclip on top demonstrates a moderate grade plantar plate tear. The short axis image on the lower left reveals bony irregularity of the lateral condyle of the proximal phalanx, consistent with an enthesiopathic process. Additionally, the short axis image on the lower right, obtained slightly distal to the one on the left, shows hypoechoic thickening of the plantar fat pad. The lateral condyle of the proximal phalanx and the thickened fat pad corresponded to the area of maximal pain with sonopalpation. This case highlights the importance of imaging the plantar plate in orthogonal views, including the condyles of the proximal phalanx. A 44-year-old trail runner experienced pain beneath the fourth MTP joint, which worsened after obtaining custom orthotics from a local running store. Radiographs were unremarkable, and a long axis cineclip of the plantar plate of the fourth MTP joint revealed a small tear, which was likely an asymptomatic finding. However, by applying additional ultrasound gel and lightning transducer pressure, a well-demarcated area of fat pad thickening with increased hypoechogenicity was better appreciated and consistent with a submetatarsal bursopathy. This was likely the primary source of her symptoms, which improved with shoe insert modifications to offload the affected area. Plantar hindfoot pain is relatively common in runners. My scanning protocol assesses both the central cord of the plantar fascia and any potential coexisting or alternative diagnoses. When evaluating the central cord, I look for variations in pathology that may